The meeting to order. Finance Committee called order. Will the Secretary please call the roll?
Director Deere?
Director Deere is here.
Director Harrington?
Present.
Director Robinson?
Present.
Director Story is absent. Chair Ryder?
Here. Ryder is here. You hear that, Dennis?
And for the record, those directors also present. Board Chair Taylor?
Here.
You have a quorum.
All right. Thank you. Can we have a motion to allow Director Deere to remotely participate in the meeting as a voting member?
So moved.
Motion's made. Is there a second?
Second.
Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
Aye.
Opposed? The ayes have it. All right. The next regular meeting of the Finance Committee is scheduled for Thursday, July 13th, 2023 at 9 a.m. Debbie, is there any public testimony?
We did not receive any registrations to provide testimony, nor did we receive any written.
All right. It does not appear that we have anyone in the room seeking to take the podium. So we're going to next go to the May 18th, 2023 Finance Committee meeting minutes. These were approved by the board at the May meeting, but are being presented for the committee's review and discussion if necessary. Are there any corrections that need to be made to the minutes? Any corrections for the minutes? Any corrections? Hearing none, all those in favor, or is there a motion to accept the May 18th, 2023 Finance Committee meeting minutes?
So moved.
Motion is made and properly seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
Aye.
Opposed? The ayes have it. We're now going to go to items under the Chief Procurement Officer. We have a total of 29. And we have our Chief Procurement Officer is taking the stage as we speak. Items 1 through 6 are for the Cook County Department of Public Health, and I believe it was be presented by our Chief Operating Officer, Dr. Lamar Hasbrook. So let's take it away.
Chair Ryder?
Yes.
Please let the record reflect that I am abstaining and will be voting present on request number 8 under the contract and procurement items.
Okay. Request number 8 we'll get to in a little bit, but we will note that for the record, and we'll note it again when we vote on those items. All right, go ahead.
Good morning, directors.
Good morning.
So I have the first six, and they're all RFPs pretty much. The first one is for vendor Flowers Communication. It is for an increase of the contract, fiscal impact of $500,000. They are a media and communications firm, and they are helping us to increase awareness and resources to advance health equity. Campaigns are to reach the communities hardest affected by COVID-19. Any questions on that one? Great. So the second one, excuse me, is for a vendor, Illinois Public Health Institute. It is to extend and increase the contract, fiscal impact $75,000. And what they do for us is they are a subgrantee, and this is the result of a 12-month no-cost extension. They're helping us with workforce and organizational development sessions and technical assistance for CBOs, again, those impacted by COVID-19. The third one is another grant, and it's to amend and increase a contract. This is McKesson. This is for fiscal impact of $499,000. It is a GPO. It is to provide naloxone for our overdose prevention initiative, opioid overdose prevention initiative. There were some questions by some of the board members who are working on that. We'll get you those by the end of the day in terms of how this program is rolling out, et cetera. No questions, I'll move on to the next one, which is an execute contract. This is Integrated Solutions Consulting. They are supporting our Emergency Preparedness and Response Unit in preparing for regional preparedness plans and other associated training. So we learned during COVID that we need to have more engagement with community. They're going to be helping us enhancing the community preparedness with the regional plan. Next is number 5. This is an execute contract. The vendor is Sage Health Strategy, fiscal impact $300,000. And they will be helping to do essentially an environmental scan, deeper understanding of the shortage of behavioral health workforce, behavioral health workers, and then recommending solutions for that. This will be a countywide scan. And then lastly, number 6, excuse me, this is for ICF Macro. It's to execute a contract, fiscal impact $451,000. The mechanism is the comparable government procurement. Again, fiscal impact $451,000. And this is to help conduct our youth survey, something called the Youth Risk Behavioral Survey. They're going to do everything from recruitment to sampling, weight the data, do the statistics, dashboards, visuals, et cetera. This is a survey we do in the community. This will be focused on suburban Cook to get a sense of the health risk behaviors for youth in the community. Again, there are some questions that were asked yesterday, and we'll be providing those answers to the board by the end of the day.
So before Dr. Hasbrook leaves the hot seat, anyone have any questions on any of these items?
Mr. Chair, I do have a question here.
All right, Dennis, you'll have to speak up and clearly into your device because it's hard to hear you.
All right, can you hear me now?
That's better.
Okay, good. Just a quick question for Dr. Hasbrook. Understanding this particular company, was there not anyone local who does the same?
I'm sorry, I didn't hear the question.
Was there not anyone local who does the same?
Is this a youth survey you're referring to?
Yes.
I believe, I'll check with my chief epidemiologist, but I believe we are going with this company. Probably the answer is yes, but not a company that's familiar with doing this survey. This is a survey that's been in the field for decades. We do it every other year. They also do it for the city health department as well. So I think that was the advantage for going with this company.
Got it. Thank you.
You're welcome.
I would like to note that this being the second finance committee meeting we've had in person since March of 2020, that there is a period of adjustment and getting reacquainted with people that you haven't actually met in person as we've turned over staff. And I will note that I was curious as I was coming up the elevator who the person that was much better dressed than I was as we were coming here. So now I've now been able to associate that with Dr. Hasbrook, who's been an acronym on a Teams meeting for since he's joined us. So for me, so thank you, Dr. Hasbrook.
Thank you, Director.
We're now going to move to request number 7 and 8. Health Plan Services, which are going to be presented by Aaron Galena, our Chief Administrative Officer for Health Plan Services.
Good morning, directors. The first item before you is a call center for crisis behavioral health services. This is an increase. We are required under our contract with the state to contract for this service with this particular vendor, and the state also mandates the pricing that is required under this contract. So this amendment is to bring our contract in alignment with the requirements of the state. And then the second item is for Canary Telehealth. This is a no-cost extension. We currently have an RFP out for population health services, and this is to allow time for that RFP process to complete and any transition if needed as a result of that RFP.
Oh, that's it. Any questions, Aaron? you know, I was getting used to, like, we have 7 for each person. I think we had that, last month. All right, any questions for Aaron before we move on to the next request? Hearing none, thank you, Aaron.
Thank you.
I think he was waiting for me to comment on the way he's dressed, his attire.
Always sharp.
Yeah. We're now gonna move to, request number 9, which is being presented by, Dr. Claudia Fegan, the, Chief Medical Officer of Cook County Health. Hello, Claudia, how are you?
I'm great, thank you.
Thank you.
Good morning, directors. So this is a contract with Crestwood, which is a new facility for us. We often take care of folks who are unfunded, and we need a place to discharge them to for continuing care. We have previously had a contract with New Care, and we've opted, this is a fairly new and a facility that our staff has assessed. We're very happy. The staff seem to be very helpful. The facility is not owned by some of the larger entities in the market that we've had some trouble with in the past. We get complaints from family members of patients and patients themselves, and so we were looking for a better facility to send our patients to continue their convalescence, improve. And so we're optimistic about this vendor who has not previously, it was previously Palos Rehab, but this is a new owner, and we're optimistic that they'll provide high quality care for our patients.
Great. Any questions for Dr. Fegan? Hearing none, thank you, Claudia. Request number 10 to 11, or 10 through 12, equity inclusion, which are going to be presented by Shannon Andrews, our Chief Equity and Inclusion Officer. Good morning, Shannon.
Good morning. Good morning, directors. I have 3 items in front of you today. The first item is a request to extend and increase a contract with Vivian Inc., who is our GPO partner. This engagement began originally to assist us with our dock and materials management area and to assess our inventory management needs. This request will take the contract through December of 2023, not to exceed an additional $981,560 to complete the implementation of a new inventory management system. And the next 2 items before you are the result of an RFP that was conducted. This is a part of our ARPA programming and is ARPA funded. We went out with an RFP to solicit assistance for housing outreach providers for the Housing and Health Navigation Program. These 2 vendors, one Housing Forward out of Maywood, Illinois, and the second is Beds Plus, will be providing services to assist with providing housing solutions for those who are facing housing insecurity or homelessness when they leave our facilities. Both of these contracts will not exceed $555,944. We will be going out with an RFP to select a 3rd vendor to provide those services in a more limited capacity within city limits. And if there are no questions, those are my 3 items. Thank you.
Thank you, Shannon. We're now going to move to request number 13 and 14, which are being presented by Pam Kassar, our Chief Financial Officer. Morning, Pam.
Good morning. I have 2 items before us today. The first item is a request to extend a contract for Bank of America leasing. Bank of America is one of our 2 leasing vendors that we use for equipment leasing, and we wish to extend this contract so that it'll be coterminous with the longest expiration of the longest lease schedule. The second item is for CCH Health. This is also a request to extend while we go out for RFP for this service. CCH Health provides the request for information, making copies of records for attorneys and so forth. And again, this will be going out for RFP, and we need to extend the contract while we go through that process. Those are my 2.
Any questions for Pam on those 2 items? on either of those two items? All right. Thank you, Pam. We're now going to move to request number 15. It is my understanding our general counsel who will be presenting on this one, Jeff McCutcheon, is joining us virtually. Jeff, are you there?
Good morning, Chair Ryder. Yes, I am.
Jeff, please speak as loudly as you can.
I will do that. Thank you. So this law firm is a registered county WVE. They're currently working on some ongoing projects for county care. The purpose of this contract is to allow them to complete their work on those projects.
All right. Does anyone have any questions for Jeff on request number 15? Hearing none, thank you, Jeff. Good to hear from you. We're going to now move to request number 16 and 17, which are going to be presented by Angela O'Banion, our Chief Information Officer. This is regarding health information systems and operations and development.
Good morning. I have two items to present to you, and they are related, so I will talk about them simultaneously. The first is for 3NetWise, and the next is for Cerner. They are both resultant from the same competitively bid request for proposal to replace and enhance our existing e-consult solution. And in choosing these two vendors, we will have enhanced functionality, including 100% interfacing with our electronic medical record, no manual steps, provider scheduling, and a number of other things, including principally that the current solution is primarily limited to FQHCs, and community clinics. The new solution will allow for any healthcare organization and managed care organizations, and as stated before, no manual uploads of test results and things that we have to do now. So this one is for 3NetWise, and the next one is Cerner. One will be primarily focused on e-consult and scheduling, and the other referral management. We wrote the RFP to allow us to select multiple vendors.
All right. Any questions for Angela? All right, hearing none. Thank you, Angela. All right. Let's buckle in because the next 11 are coming from operations and development, and Craig Williams is in the driver's seat now.
Yes, I didn't want to disappoint, so I made sure to bring a lot this month.
You know, Charles, this has been this new system, you know, that we developed here in the last, what was it, probably the last 6 months, a year. You've got to love this now.
Oh, absolutely.
You just
Definitely a lot having him right next to me now. Okay, the first one I have is from Metropolitan One. It's an increased contract for $910,000. This vendor provides our valet service here at Stroger as well as at the professional building. This contract expires 12/31/23 and will be going out for an RFP at that point. Avidex Industries, it's an increased contract for $66,134. The contract period is 1/1/22 to 12/31/27. This vendor provides our television service for our inpatients at Stroger and Provident. And this particular request is to add 5 additional television systems at Provident for a recent bed expansion we did there. Jones Lang LaSalle, JLL, is an extended increased contract totaling $2,216,176,000. JLL currently provides management staff to our buildings and grounds department, Joint Commission survey prep and support, an energy manager resource to assist in lowering energy costs, as well as technology to support management of our facilities. In this new contract, we're asking to increase our management staffing from 4 FTEs under this contract to 7 FTEs to really provide some after-hour support at both Provident and Stroger, where we've struggled in terms of management response there. I will mention this contract was originally brought into a 6-month emergency contract. We've updated it twice, the most recent being a 12-month amendment that runs through 8/5 of 23. That particular 12-month amendment was really when we put in this management staff. And I'd say during my time here, we've really kind of built up that staff. And to me, it'd be important to extend this for another year. And we're committed over the next 12 months to convert these management team members to CCH employees. Obviously, we'd encourage the ALL team to apply, but we'd open that up, and then we do an RFP for this continued kind of oversight support. Any questions on that one? Okay. MHNU doing business as Medical Home Network. This is an extended and increased contract of $492,000. It's a 6-month extension through 11/30/23, and this is directly related to the 2 projects that Angela presented. So this is our current vendor for e-consults and e-referrals, and so this 6-month extension would allow us to continue this service as we're implementing the new vendors for our e-consult and e-referral. Pickens and Kane is an extended increased contract for $175,000. Contract currently runs through 6/30/23, and it was brought in through an RFP. This would be a 12-month extension through 6/24. The vendor provides warehouse handling, inventory reporting, and delivery of furniture, fixtures, and equipment across our facilities. HOH Water Technologies is an extended increased contract for $148,727, originally brought in through an RFP and a 5-year contract which expires 6/30/23. This is a new 12-month extension we're requesting, and they provide preventive maintenance of our water purification systems at Stroger, and this covers the RO system for dialysis, the central powerhouse, and the central lab. Moises Landscaping is an extended increased contract for $120,000. This was currently a 3-year contract that was acquired through an RFQ that expires 6/30/23. New contract would be a 12-month extension through 6/30/24. And this vendor provides landscaping at our ACHN clinics. And while I'm discussing landscaping, I hope you all noticed the beautiful landscaping that we installed in front of the professional building and across the central campus. Not to put a plug in, but there you go. Yes.
So, but that landscaping, is that done by done by county staff, or is that done on contract?
It's done on all of the landscaping is done on contract.
Okay. Same contractor?
Yeah. It's a different contract here on campus.
Yeah. Does Moises Landscaping, is that mostly grass cutting, trimming, and cleanup work?
Yep.
That's what I figured.
Okay, Protection One is an extended increased contract for $26,500. This contract would expire 11/30/23, and this vendor provides intrusion allowance for our ACHN clinics, and this particular request is to add equipment at Arlington Heights. Shared Medical Services, here we go. This is an executed contract totaling $8,176,000. Contract period is 7/1/23 through 6/30/26, a 3-year contract. We selected this through an RFP, and this vendor is going to provide total turnkey services to locate 2 mobile MRIs here on the Stroger campus, and they'll also provide staffing for those machines. And this contract is being implemented to address a backlog of MRI studies we have throughout the system. Studio AH is an execute contract through CIP for a total of $960,000 that was acquired through an RFQ. Contract period is 7/1/23 through 6/30/26, and they're going to perform a fire sprinkler evaluation here at Stroger. Scope of project will assess the overall condition and make recommendations on how to move forward with our fire protection. Polymedco Cancer Diagnostics is an execute 3-year contract totaling $268,000. It was sourced through a GPO. Contract period would be 5/23 through 4/26. And this contract is provision of reagents, consumables related to fecal immunochemical tests to screen for colorectal cancer. And the last one I have is Integral Life Sciences. It's an execute contract for $174,000. This is a one-time capital purchase to acquire intracranial pressure monitors for clinical and patient needs in our neurosciences service line.
Any questions for Craig? All right, thank you, Craig.
Thank
And I'd like to just quickly acknowledge that Director Story joined us as we went through the contract procurement items, and noting that Director Robinson intends to vote present on request number 8. Is there a motion to approve item 4A, contracts and procurement items containing request numbers 1 through 29, subject to completion of review by contract compliance?
So moved.
Motion's made and seconded. Any discussion on the motion? Again, noting Director Robinson's present vote on request number 8. Hearing none, all those in favor signify by saying aye.
Aye.
Opposed? The ayes have it, and we will note for the record the present vote on item number 8 for Director Robinson. Next, we have Charles gets to talk. All right, I'm excited about this. Charles, I know you have a few items to present, so why don't we just take them in order, and the floor is yours.
Okay, great. Okay, thank you. Good morning. Charles Jones, Chief Procurement Officer for CCH. Before we move off contract and procurement items, the 29 items all require responsive letters from the Office of Contract Compliance. We have 13 back, so it's 16 outstanding at the moment. Okay. So moving along, what you have before you on the board here are procurements under the authority of the Chief Executive Officer, contracts under $150,000 for the second quarter of 2023, March, April, and May. There's 21 items here. We'll break down a summary of the items for 6 grant-related contracts. That's 4 capital equipment purchases and 4 independent consultants, contractors, and then several TPO contracts as well. Looking at some of the higher dollar ones, the first one for CAPSA, $114,000 was for equipment for till collection devices. CDW government, we bought the sector contractor application for $111,000. The Center for the Urban Research and Learning for Loyola University, a grant-related item for data collection analysis on flexible housing pool, $101,000. Jumping all the way down to Landauer Inc., that was radiology dosimeters film badging for $106,000. Optimus Hospitals and Pediatric Subspecialty 24/7 neonatal in-house coverage for L&D at Humboldt Park Health, $135,000. Flipping over to the very last page, that's to the Board of Trustees for URI. We did physician services for female pelvic medical medicine and reconstructive surgery, $149,000. And then lastly, an independent contractor for with Rashid bin Patel for $149,000, grant funded for a grant data specialist. Any question on it? The 21 more contracts that are listed here.
All right.
Okay, thank you.
Go ahead.
Okay, next item before you are the minority and women business enterprise metrics for the month of April. Looking at the second column from the right here, month of April, those 46 contracts were before you. However, you may remember that about 28 of somewhere between 20 and 30 of those were grant-related contracts where the Department of Public Health with building health to community. So those contracts does not have goals on them. So we have 8 specific contract goals with a little bit over $87 million. Only one of those were a MBE prime for $174,000, and 6 of those were subprimes for $26.368 million. So somewhere in the range of 30% on those 7 contract items. Unfortunately, and I always say unfortunately because well, we don't like waivers, right? But we did have a waiver for, a 1.15 million. That was a health plan service contract that, had provided directory tool that did not allow us, any participation there. Looking all the way over to the far right with the very last column there, so 26 contracts year to date, $168.2 million, 77% goal-wise opportunity. 5 of those were prime for 17.7 million, a little bit over 11%, and 16 were subprime for 47.09 million and 28%. So you total that up, 21% and approximately $64.8 million of participation, a little bit in the ballpark, and 39% year to date. Next slide, Debbie, shows you, right?
So those are pretty good numbers for the month of April, right?
Yes,
But for
but still, I mean, when you look at total contract total, it was only 7, so not 8. So, I mean, it's good to talk about, but I'd like 1 month does not equate to a trend, so I'm not too excited about it, but it's okay.
Okay, all right. I appreciate the fact that you are never just merely satisfied that you're.
Absolutely, absolutely. We always got work to do.
That's why Dennis appreciates the work that you do too, so.
Yes, sir. So here you see with the bar graph, April in the range of 30%, then year to date, 39%. Any questions?
All right.
All right.
And then we don't have any emergency purchases, to be presented this month, so.
No, sir.
Charles, thank you for everything. Appreciate it.
Appreciate it.
Next up is our Chief Financial Officer, Pam Casara, who's going to present first, our, grant award related items.
Thank you, and good morning again. Pam Casara, Chief Financial Officer. The first item up, which is a little difficult to see, is the receive and file grant awards and renewals. There are 2 grants listed here. The biggest, $5.5 million, related to COVID response and resilient communities. That one is Dr. Hasbrook's. If there are any questions, he could probably speak to that.
All right. That's it then on that. So before we go to the financials, is there a motion to receive and file item 5A, grant award related items? So moved. Motion's made. Is there a second?
Second.
Motion's been made and properly seconded. Any discussion on the motion? Hearing none. All those in favor signify by saying aye.
Aye.
Opposed? You guys have it. All right. We're now going to go to the April fiscal year 2023 financials. Go ahead, Pam.
All right, thank you. So for the 5 months ended April, we came in $162.2 million favorable variance to budget on an accrual basis, and on a cash basis, we are at $108.4 million favorable as well. Couple key drivers on that. On the revenue side, on the hospital and clinic, favorable net patient service revenues due to a combination of higher inpatient volumes, higher than budgeted directed payments, receipt of some prior year cost report settlements, and then Medicaid retroactive rate increase. And then on the county care side, also favorable variance related to the membership and the capitation associated with that due to the pause on redetermination. On the expense side, the key driver there, county care claims expenses unfavorable to budget, again, due to that higher membership. County care came in at $16.1 million favorable, and the membership remains over 450,000, which is greater than budgeted. And again, this is through April. Next slide, Debbie. So again, as you look at the financial statement, actual numbers, I'll draw your attention to the total revenue line, $292 million, better than budget, pretty evenly split between the hospital clinic side and the county care side, about $150 million each. And then again, on the expense side, total operating expenses, $109.4 worse than budget. And then again, that primary variance there, the medical claims expense line, with a variance of $124.5 million. But bottom line, net income, $121.2 million. The budget was actually to be negative. Again, we budgeted as we did because we thought redetermination was going to have started at the beginning of the year. It has not, so we are $162.2 million ahead of budget year to date. Next slide, Debbie. So volumes. The volumes are the key drivers of our performance, both on the hospital clinic side and on the county care side. So we like to look at these and see how we're doing to budget. Again, you can see Stroger on the inpatient side, very strong, 30 patients per day, better than their budget. Both Provident and Stroger continue to lag behind budget on the emergency room visits, but are ahead of budget or at budget for Stroger on surgeries. And then ACHN in total is ahead of their budget. In total visits, the split between primary care and specialty care do not line up with the budget, but again, in total, better than budget. And then county care membership as well, better than budgeted as redetermination has not begun. Next slide, Debbie. These graphs, again, just depict the same information over time. You can see after the initial dip in 2020, we are pretty much back to 2019 levels and pretty consistent across the board in all areas. Next slide. Payer mix. So not a lot to talk about this month, but as we've mentioned with the redetermination beginning and now the recent announcement about the health benefits for immigrant Americans and the hold on the expansion or adding any more to the Medicaid rolls. We'll be watching this to see if there is a shift and Medicaid starts to come down and uncompensated starts to go back up. But again, as of April, we continue to see all payer categories actually increasing and uncompensated care decreasing. Next slide.
So,
Yep.
how do you, as we're trending out of a lot of things related to the pandemic, how do you and Israel feel about where we're at with payer mix and our balance, and how do you see it shaping up and what the sustainability looks like?
Yeah. So we've been working with the downtown, actually to forecast that. They just released their preliminary forecast for the rest of this year and next year, and we are anticipating a shift due to redetermination. We're hoping, optimistically hoping that it won't go back to like 2019 levels, but somewhere sort of in between. So we don't expect everyone to fall off the Medicaid rolls. We hope that people have enjoyed their experience with county care and will re-up with county care. So we're sort of projecting to be somewhere in between, maybe around maybe a 4% shift is what we're envisioning right now.
And you know what I would add is that it's not a simple thing in healthcare where you think you're going to have a reduction and that it's just a static reduction. So as many of you, as our finance committee are aware, just to make sure we disclose it, finance has many funding programs. So sometimes you will see a reduction in one, but we're able to recoup in another, and we're able to move forward. A lot of the financial presentation work that we have here, as you've seen across the industry and news, it's not just COVID. So people say, oh, we're doing well with COVID. It's not just that. There are a lot of different things. We do have more people on rolls. We do have more people on others. But across the industry last year, the average hospital had a negative margin. And so we are performing financially very strong as a system, and that has been through Pam and her team, but many things that are happening in the hospital that are not just resilient issues. We have done a much better revenue department that has been structured and is able to capture and look at our revenue. We've done better with qualifications. We look at our program. So going forward, while we do expect some decreases in other areas, we have been planning for that by being able to expand and have revenue operations look at how we're capturing and charging, billing, and documenting better. We have some things that are coming online, and then we're going to look at how it comes over. As Pam said, when it all comes back together into the soup, it's about a 4% differential, but we are going to put things in place that at least keeps this level and moving forward to make sure that we continue our growth. But right now we're a little concerned. We'll see where everything comes in. We have some missing pieces that we need to communicate with our state partners, so we're waiting to get some information. But so far, we're confident that it will be probably about a 4%, but we'll be able to structure that and mitigate it to make sure we stay resilient and moving forward.
And so the reason why I ask is prior to the beginning of the shift of everything in March 2020, we spent a lot of time looking at payer mix and how we could make adjustments to payer mix, and then the whole game changed, and everything was framed by COVID, even though the adjustments we were making, the payer mix, were driven by the ACA and making sure, in county care, making sure that we were capturing, getting people signed up. So so it just occurs to me, and some of this is happening like as I'm sitting here back in my more familiar environment, and having reflecting back on when I used to sit in this room and recontextualizing it, is like, where are we at in this new, because you guys have done a phenomenal job coming through. I mean, I think we should also talk about, our transition. When we had a leadership transition, we had our interim CEO who did a great job, Andrea Gibson, who is now our chief strategy officer, and we started reshaping all this, and you guys have taken it to another level. I feel very comfortable in how we look at things strategically, and how much more it feels like we're much more nimble and layered in our strategies. So I just wanted to get some context on it, and I do feel like we are a much more resilient organization. So thank you.
I have a question. I was going to save this for later, but this is going back to the key revenue indicators. I'm looking at the.
Yeah, we're actually going on, I'm sorry, Debbie, next slide. Next. Yep.
I'm not sure if this is an answer, but it may. The question I have is, when we look at Stroger, Provident, and ACHN, and the revenues are driving up, why?
Yeah, so inpatient volumes are high, much higher at Stroger. Providence just slightly behind on their inpatient side. The revenues received on the clinic side are much smaller, and the revenues we receive on the inpatient side are much higher. So the mix, so we've got, several dynamics going on here. You got the mix of inpatient to outpatient. You've got the mix between payers. You've got, sorry. So there's a lot of key, plus as Israel alluded to, we're collecting what we are entitled to better. So there's just a lot of pieces. We've done rate increases, which had not been done previously in the past 10 years on certain services. So, I mean, it's a combination of all of that is driving net revenue. Gross revenues have stayed pretty consistent, but net revenues have improved.
Yeah, what I would add is that it's as Pam said, it's a combination of a lot of things. Part of our strategic planning that, Provident, we've rehired almost in the brand new emergency department. We opened 2 ambulance runs. We expanded our medical surgical hospitalist. We've hired an additional management and focus on our ambulatory care division, who works to look at our structure, our patients, our patient empanelment, throughput. So a lot of the things that we presented in the strategic plan that we give updates on are coming into fruition. So it's a mix of also patients are coming in. So it's a few more things, but we're going back to normal patient volume, but we've been able to capture on better collections and then also better operations, and it's giving us some lift in capacity and volume.
So if you're giving the credit to the increase as a result of getting more money in, that maybe previously you weren't denied, you also mentioned the idea that you're getting more patients in.
That's how we get more money in. So it's both. It's volume and patients. So that's why I said when we increased emergency department staffing, we opened 2 ambulance runs. Provident went from an inpatient census of about 9 to about 30. It's break even for the first time in about 30 years. And so before it was losing money and drawing from our net revenue, which Pam said our net margins are better. Now it's breaking or contributing, as are most of our service lines. And so when you look at the budget, you see that our positive margin is a combination of both county care, but also our patient revenue services are up over $100 million from projected because of better collections, increased volume, and more service.
Okay, so when I look at ACHN, I see there's a big increase there, it seems like it. What would you attribute that to? It says in the specialty care visits.
Yep.
But what's causing those folks to come in, whereas previously they weren't coming in?
So it's 3 things. One, you can see from our volume that we have much better volume and how we're getting our clinics and throughput. So we're able to get more patients in per visits. We've optimized our scheduling software. We've looked at our visitations. We have more providers who've come in. We're doing more services. But the other thing also is that we've done better at collecting. We weren't always capturing all the charges we were doing in the outpatient arena, and we weren't always capturing minor surgery procedures. So we were doing them, but we weren't capturing them. And so Pam's team has done a great job. So as we said, it's always a combination of both. We're better at capturing what we were doing and billing and collecting for it, but we've also seen better organization through Dr. Fagan, our ambulatory care staff, and their teams coming together, and Dr. Irons and Craig's team on the ambulatory care side, in creating better scheduling, better throughput, better processes. So that's why the visits are going up. So not only are we better collecting, you have more visits, more access, more patients, more procedures, and so that's generating more revenue.
So what you're describing to me sounds like it's sustainable. This is not a fluke. This is better operations.
Yeah.
Cool. Very good.
Yeah, I think the biggest difference, Sam, and the way it ends up reflecting more dramatically is because, you know, when you're doing a budget, and this is a governmental safety net, right? So you're budgeting, you know, and we have fallen victim of doing this the other way, where you set aspirational goals and then you budget to the aspirational goals versus incremental, instead of incremental operational, like, planning, right? Like, this is what we did this year. Let's increase it incrementally, but let's not budget based on, you know, where we think we can go, because that's setting yourself up for failure. And we've done that in the past. We're exceeding what the natural trend of growth, I think, would be because of how well we're performing. So I think that is one, that's smart in how to set the goals, but now we're seeing all these things coming home, right, on terms of the planning from probably the first year putting the new team together. So it's for me, it's just especially satisfying because, again, I am now the longest tenured person here. Is that right, on the board? So it's night and day to see the strategies, not putting the aspirations on paper ahead of the aspirations actually being actualized and building out. So,
yeah. In short, it's many great leaders across the organization and many great employees doing a lot of projects that together are making a difference. But we keep in mind that, you know, if payer changes, like we all of a sudden don't get one type of payer qualified for, what that happens, we bring it back together. But the growth and the ability to move forward is sustainable.
And it speaks of tremendous leadership, because not only does the revenue allow you to function, but the mission of the hospital is to get out to serve folks. And by your numbers going up, it sounds like the mission is truly being accomplished, and that should be applauded.
And I'll totally
So perfect segue, and I think he's on the line, but I want to give kudos where kudos are due, which is to Curtis Haley, my Chief Revenue Officer, who really has, over the last 2 years, built his team and put in processes that are making a difference. As you look at these key revenue indicators, he is benchmarking us against national HFMA, Healthcare Financial Management benchmarks for hospitals our size, and you know, achieving those targets, setting targets and achieving the targets, driving down AR days, driving down AR, you know, greater than 90, increasing our cash, et cetera. And so again, I do want to give kudos where kudos are due, because he's done a great job. Any questions? Next slide, denials, similar.
Not a question, but an observation. But it also may mean something relative to patient care too. And I don't want to lose that, because we're talking about money. And our mission is really to serve people.
Right.
So,
and the more
job serving the people.
The more we collect, the more we can serve. So same on denials. You know, we want to stop the denial from happening in the first place. And we monitor both as a percent of cash, which is a benchmark, again, a national benchmark to be less than 2%. We're well below that. We're so highly governmental, we monitor that separate as well. In the right bottom corner there, government denials are almost next to nothing, which is great. And then the denials we do have, you know, the multicolor graph in the middle there. Multiple reasons for denials, from you know, some that are revenue cycle driven, like timely filing, and some that are not, like medical necessity. But again, the overall trend is down, and we'll continue to improve on this. Next slide. This one, our public program expenditures, is just shows over time that this has been pretty consistent in terms of dollars spent, not just the traditional charity care and uncompensated, which is bad debt, but the services we provide, CERMAC and Department of Public Health, as well as other programs as well. So. And then next slide, our savings initiative. So we have $47.5 million budgeted for this year in contract renegotiations and driving down our costs. So far this year, we would have hoped to have been at 512 for 42%. We're at 31, so running a little behind. You can see the yellow stoplights there just mean we're not on target, but we do anticipate those items will catch up. They're slated to start a little later in the year. And then last slide, county care, again, came in $15.6 million. They're budgeted at $450,000 loss. Again, assuming that redetermination would begin, and it has not, so they are $16 million ahead of their budget. And the story is the graph at the bottom, right? The red bars are the actual membership, and the blue bars are how we budgeted for them to go down, and budgeted the associated revenue and expense to correspondingly go down as well, and that has not happened yet. Any questions?
Any questions for Pam?
I'm just curious. With health plans, you said the membership has not gone down, and I think it started at the beginning of this month, I believe.
Yeah, they got their letters in May. Aaron, do you want to speak to that?
Aaron Gleaner, Chief Administrative Officer for Health Plan Services. Individuals received their first batch of letters in May. The first month that individuals potentially would lose coverage originally was planned for July. We have heard that the state's going to provide a 30-day grace period to individuals. So now the first potential coverage losses we're expecting would occur in August. But we should have some initial data here in the next week or two on how many individuals would have lost coverage in July, absent that 30-day grace period.
Okay, so you have an idea of who you have been able to get redetermined, but then there's a gap of those that have not, which is what you just made the statement to. Is there a plan to try and find a way to find these folks? Because I understand the issue. The question is, how do you find them? And I know you're trying everything, so it's not a question of your efforts. It's just, okay, how big of an imagination can we get to try and find them?
Yeah, absolutely. I mean, our strategies are pretty much every touch point that we have with a member, and then working with externally other organizations and how they have touch points with our members as well. That includes providers, that includes community-based organizations, Chicago Public Schools, for example. So it's a fairly broad strategy, and then we'll also be looking as we get some of that initial data back. For example, we'll be able to take that and break that down by zip code to see if there's concentrations in certain zip codes where we're seeing disproportionate amount of individuals that are losing coverage, and then we can target very specifically towards that as well. So we've got a very broad, comprehensive strategy right now for how we're outreaching and trying to touch and assist members through this process. And then as we get some of this data back, we'll be able to incorporate that and make adjustments to those strategies as we go forward.
Two questions. On the Chicago Public Schools, because my kids are in Chicago Public Schools, well, at least one of them just graduated, and that's an experience. But the question I have, I received a text advising me to do redetermination if it applied. Are there any efforts to reach out to maybe say to the principal or guidance counselor, the people who actually experience kids who are having these difficulties and have to deal with the after actions, they would actually have a pretty good idea of how to contact at least the kids or the parents associated with them.
Yeah, absolutely. I mean, I think we're trying to explore what avenues we can with like Chicago Public Schools, for example, and what ways we can work with them to communicate. And there's a variety of potential ways. Some of that we're still working through, but I could definitely take that specific item back and see if that's feasible.
And I assume the more basic one is the idea of utilizing pharmacies, since everyone has to go there eventually at some point in time.
Yes, absolutely. So point of sale messaging when individuals are picking up their script is another avenue that we have in place now with our current PBM. We're in the process of going through a PBM transition, and so we're working through that process with the new PBM that's going live on July 1st. But absolutely, point of sale messaging's going to be critical, and it's also likely, unfortunately, when someone does lose coverage, if they're unaware of that and they go, that first day to pick up their script, a lot of members that may be their first, experience or understanding that they have lost coverages when they are at the pharmacy. So it's a really critical contact point.
And this may not be feasible, but I'm dwelling on this because I understand just how important this issue is for the organization. Can you utilize boots on the ground to go to the pharmacy or to the, we're in summer now, but to the CPS to actually try to really put a strong effort to capture these folks? Because I do recognize just how elusive they really are.
Yeah, so there are some restrictions on the way that we can provide assistance, but we can definitely do community events. They have to be pre-approved by the state, for example. But yes, there are opportunities to do events like that where we do have individuals there that can help walk people through the application. And we have been already starting a series of those events, certainly with the list of members that received their letters in May, and we'll continue to ramp that up over the course of the year.
And another thought too at the pharmacy, because the pharmacies have a tendency to have a personal relationship with a lot of people. And when they come there and they recognize they can't get the script, and they'll ask the question why, and at that point in time says, okay, hey, you can call this number right here to get y'all to speak to someone within your organization. And again, because the whole idea, which I know you know, but when you find one contact, man, it's really, if you can't grab it then, you may never see it again. And 30 days makes all the difference here to make it easier for them as well as for the organization and for their health. Just thoughts. Thank you.
Absolutely. Thank you.
I just have a general question. I don't have any kids in the Chicago public school system, but can anyone just respond to, does every school have a school nurse here in Chicago?
No, I can say
They do not?
No. And the schools that need it most do not, if you really want to answer the question.
Because Israel, you know this, that in Fort Worth, J.P. Stevenson, one of the things that they were successful about, because the schools there in Dallas-Fort Worth have nurses in all the schools, and that crosswalk was very easy for the folks in Dallas-Fort Worth area because of the school nurses.
They also have one nurse for several schools, and they may all be in one day a week.
Wow. Yes. There's a gap.
So actually, you present an interesting question. If we look at nurses from a different perspective, the schools are looking at it because they need it, but the schools only get the money that they're allotted. But if there's a broader audience that sees an importance for those kids, there may be a different way to fund nurses to actually achieve the objective that everyone's been trying to do, is to get at least a nurse in one school. Because the issues, as we know, go broader than just the regular health. Well, I'm preaching to the choir, so I should stop. But, I have kids here, so I see this stuff. And I used to be on a local school board, and some of the stuff I heard there, when some of the kids speak, it would just blow you wouldn't think a kid has to go through this kind of stuff.
I have a friend of mine who's also, I believe, very interested in this specific topic. He's at City Hall right now.
Let us get. I want to get first.
But I believe we've talked about this issue in the past. So.
Yeah. I mean, it's something that we can definitely review, and there are some There, having worked on the school program before in a previous life, there are some things you need to go through, but we definitely do work with the school, especially on the suburban side, through our public health department and through others to see what we can do to continue to augment services. And we currently have some ongoing conversations with some schools about how we can be partners in health and what we can do to extend that. But we definitely can go and review that and look at it a little bit closer. Part of it for schools and general consent and things that fall in because they're minors, but there always is a way. So we can have a conversation to see what, or do some review to see what could be done to be better partners and what we can do in that area. I don't know, I'm not saying we can solve or take on nurses in all schools, but we definitely can see how we can be a better partner, both through our public health department as well as through our direct services.
Well, it was very
Mr.
effective.
Chair?
Very particular, I know Israel knows this, in the Dallas-Fort Worth area, because having the school nurses in each school, it was a conduit because they had access to the child, therefore they had access to the parents who were not utilizing the health system. So that was they cast a broader net. Yes, they had the school nurses for the children, but the intent, the externality was that now we could have parents who were not utilizing the healthcare system. We could pull them in because when they were there with the child for follow-up care, you turn to the parent and said, well, when was the last time you saw a doctor?
Well, if you look at the argument of how much money does the county expend to people who are not necessarily, they don't have insurance, or either they come in when they're really impacted by a condition, versus if we had nurses that come in and there's a cost associated with that nurse, but the preventive care associated with having that person there, I just wonder how the economics would actually shake out, because I think everyone in the room understands prevention is far better, and that could be a budgeted cost, versus if I have someone coming in and they have this condition, now I'm going to experience a $20,000 or $30,000 cost, and by the way, they don't have insurance, but they were eligible, but they didn't have it because no one was able to find them because they are so elusive for whatever reason.
Yeah, what I think we can do, and we can bring back, there's some opportunities, care management is a beautiful thing, from even just a financial perspective and finance and prevention. Since we're in the financial world right now, I think what we can do is look at how we might be able to utilize the resources we have to engage our patients a little bit closer in prevention, what we can do to partner, how we can get better access. County Care has some great work that we do, and we do have a lot of children as part of our plan that we can look at and see how we can do better outreach, how we can work with partners, especially in disease states like asthma, other things where schools could be really essential in helping to build those partnerships for these larger expansions. And then we can look at working through our, as we said, our public health department as well as our system to look at what we can do and start some conversations and come back and see what we can present. So we'll definitely look at how we can engage people more and what we can do to be more present and have some of those conversations.
It might be worthwhile.
Otis, real quick, we're getting a report that you need to be you're not on the microphone, so we're not picking up the comments for the recording.
Oh, I just real quick, I just think that, Israel, it might be worthwhile just to contact and see if those programs that they had at J.P. Smith, in Dallas-Fort Worth, to see if that school-based program, because the intent was to capture the family by treating the child, because if the parents was there in the room, it was a simple question. Have you had a physical or that other?
So the first step is probably, not to insert myself, the first step is probably to look at, we have to talk to the president about engaging with Mayor Johnson and Pedro over at CPS to see as we're talking about school-based programs and what they want to do to expand it and how we can layer into it. So that way they can expand their school nurse program and have us as a partner, and partner can mean, pursuing grants together, things like that, because they have what we need to do is support their existing infrastructure and then layer our infrastructure on top of it because of the way we're all constructed, because we would have to first see how we would be able to work with that, because it's going to be a complex system. But I do think that there's potential that with the mayor having been a commissioner and understanding how there could be strategic opportunities. But I think we've got to probably first talk to President Preckwinkle before we jump into the middle of CPS.
Right.
Just sort of with a lot of elbows.
And
So-
as I said, I don't want to propose that we're a solution, and even the clinics that John Peter Smith and Parkland and others have run, I have known them, their specialty. They're not necessarily running all of the school nurse program. They create a few clinics and some opportunities and things we can definitely look at, borrowing models on, that work.
From J.P. Smith.
From getting them, John Peter Smith and Parkland have some programs, that they have their specialty clinics, inroads, exactly what Chair Ryder just said, how you connect with the existing infrastructure.
Sure.
And how they partner. And so we can definitely have those conversations, look at some models, look at what we can do to be engaged with our youth. And, but I don't want to, bite off more than we can chew.
I just want to jump in. Having worked in senior management in both the state and city health departments, one of the things that I gained an appreciation for is how big government is in Chicago and in Illinois. And we're talking about separate entities. And so I think that we've identified an opportunity, but we have to be realistic. There's a lot of other discussions that are going to have to take place. And this is exciting, but it may take a while before we have some concept or idea that everybody can buy into. But we've opened the door to a discussion I think will bear fruit in the future and may result in maybe having some more expenses up front, but down the line, having some payoff and reduce costs moving forward.
We're also recognizing too that I think all entities have recognized that mental health is a big issue. And that in and of itself, that platform allows all of them to come together, because I think all of those entities have identified mental health as a crucial issue from a variety of standpoints. And if nothing else but that point, that would serve a great service to the people of Chicago and Cook County.
Yeah, I'm not disagreeing with you. I'm just making the point that these are large systems.
No, I agree.
Public schools are not a part of city government structurally, so there's a separate system.
Yeah.
But the superintendent is actually chosen by.
Currently, but that's going to be changing, and a lot of the reason why the superintendent's chosen is because of the way mayoral control over the Board of Education. All that being said, you know, Joe's, and I'm going to move the conversation because we could take this offline. There are, Joe correctly points out that there is opportunity. The government here, which I think is appropriate, we have a big government that's appropriate for the amount of density we have, which, you know, outpaces places like Dallas-Fort Worth, which has a much smaller government, which allows it, which is a deficit in a lot of different ways, but allows it to do stuff like do some things that are a little bit different, but not probably as expansive as what we probably think it is. But we can do something probably more transformational. And I think that Israel and I, with both of our shared government affairs experience and his healthcare expertise, we will engage with this and keep folks updated and maybe tap into a little bit of Joe's experience too, and Sam's excitement. We'll come back and see if there's a program. I'm sure someone's already reporting back that there's a thought here that we could build on.
Absolutely.
So, all right. Thank you. And we also have Director Deere has a question or a comment.
I do. Thank you so much. And great conversation.
Dennis, get really into that microphone.
All right. Can you hear me now?
Yes.
All right. So my question was back to the making sure that we get all of our people back for who are on county care. Are we reaching out to commissioners, particularly those who are in underserved communities, and making sure that they have a social media kit, making sure that they have something they can pass out at festivals and or invite Cook County Health or County Care out to festivals? Are we doing that? Because August, the month of August, the calendar is full of festivals.
Yes, Commissioner Deere, to your question, we do have READY information and kits that we've provided out to commissioners, and we'll also be integrating work with commissioners into those community event schedules that we're working through. Again, we have to get state approval for a number of those, but certainly we're hoping to leverage that as much as possible.
Yeah, and Commissioner, what I can add from the health system side and patient advocacy, what we have done across the board is to make sure that we have sent the flyers, the logos, the information kits, and the links to at least 7 languages of literature where people can get the information that they need, and have been pushing out to all the staffs to put it on their web pages to access it. We can also, we're advising everyone to just keep doing it, because while we are concentrating on the ones that are maybe missed in this cycle, the other thing that we just want to remind everyone, and it's the trickiest part about this campaign, is that it's a rolling 12-month campaign. So even if we miss some this month, there will be a whole new batch that will be open getting letters, and then they will be trailing while a new batch gets letters. The rolling process is that you need to target everybody always with the same message, which is if you are on Medicaid, if you have this coverage, make sure to reach out, make sure to go to the website, sign up, look for this letter, and make sure you're taking steps. And so what best that we can do to make sure that we don't lose or concentrate on the tree instead of the forest is that we need to make sure that we are advocating for everyone to do what they need to do and to look at the information they need to look at and be engaged. So what we can do and what we've done, and we'll do it again, is we will definitely share it to our county commissioners, but we're sharing it with our public advocates, with our network. We are putting everyone out there. We have created a hotline. We have people staffing it. We tell them how they can link in, and we have the commercial information going out. So if you're going to be out at fairs and locations, we definitely can work with you to give you information to make sure that that's out there, and look forward to partnering. And we'll make sure that our team with Letty and team reaches out and is able to give you all the information that we have available to our patients so that they can register and sign on. That would be probably the best linkage, and just every opportunity you can make a plug, and we have links that can revert back to our webpage where people can sign up. So we'll work with your offices to make sure that that information gets distributed.
Please do. And when it comes to us as commissioners, and with that hat on, share and share again, because we get so much information that we may put it out there once, but we need to put it out there 3, 4, 5 times. So, share and share again. I appreciate it.
Absolutely. We'll be sharing it all throughout the 12 months. So we remind everyone, we're just getting started. This is round 1. We have 12 more. So we'll keep working with everyone as we move forward. And then for the financial aspect of it, we will be bringing back to the board with Aaron a reflection of what the impact is and what our estimates are. It's a little early on because it's the first round, but as we go through the next 3 phases, maybe in about 90 days, Chairman Ryder, we will have an impact assessment that Pam and Aaron can reflect what that's at least a trend line for the first few waves. So if you give us between 90 to 120 days, we'll have a real assessment of what that impact is.
Excellent. Thank you.
Thank you.
Any other questions? All right. Thank you, Aaron. Thank you, Pam. All right. We have worked our way through the agenda. We have passed all necessary motions to move that agenda forward. I want to thank the staff. While we had a robust discussion here, the reports on everything else, I think, is as smoothly as we went through the contracts, procurements is a testament to the work the staff does on briefings and keeping everyone updated. So with that, our next meeting, as I mentioned at the beginning of the committee, is going to be on July 13th at 9 a.m. And with the agenda exhausted, we are adjourned. Thank you.
Thank you. Thank you.